last 30 minutes, roughly, of today's meeting to do some committee business in camera so that we can plan for the coming weeks. Today's meeting is taking place in a hybrid format pursuant to the House Order of June 23rd, 2022. A few comments for the benefit of witnesses and members. For those of you...
Monsieur le Président,
Chairman, you'll need to adjust the sound, please, because I'm not hearing very well the interpretation. It's not really coming through. And my mic is pretty high up, so there is a risk of an acoustic shock. It's a question of balance. And your sound, well, I don't know if people are hearing your voice well, so could you adjust that from the very outset, please?
Merci, Monsieur Thériault.
Thank you very much, Mr. Thériault. We're busy trying to do some adjustments, and I hope that's going to be resolved very quickly.
All right. I think perhaps I will reread the opening until you tell me that everything's okay, and then we'll pick up where we left off. So this is meeting number 55 of the House of Commons Standing Committee on Health. Today we're meeting for an hour and a half with witnesses in our study of children's health, and then approximately 30 minutes at the end of today's meeting in camera so that we can plan for the coming weeks. Today's meeting is taking place in a hybrid format pursuant to the House Order of June 23rd, 2022. And I will now make a few comments that have become all too familiar for the members, but maybe the first time for our witnesses. Est-ce que ça marche?
Is it working well for you now?
Okay. Monsieur Thériault est content?
Mr. Thériault is happy. That's good. We can continue then.
Interpretation for those on Zoom. We have a couple of witnesses on Zoom today. You have the choice at the bottom of your screen of either Floor, English, or French. Dr. McLaughlin, you can use the earpiece and just pick the desired channel. Screenshots or taking photos of your screen is not permitted. The proceedings today will be broadcast on the House of Commons website. Comme requis par notre...
In accordance with a routine motion, I'm informing the committee that all of the connection tests have been carried out in advance of the meeting. And everything is okay on that front.
I'd like to welcome the witnesses who are with us this afternoon. We have Dr. Andrew Link, the Chair of the Department of Pediatrics, Faculty of Medicine, Dalhousie University. Dr. Link is also the Chief of Pediatrics at the IWK Health Centre and the past President of the Canadian Pediatric Society and Pediatric Chairs of Canada. Dr. Link is joining us via video conference. We have with us in the room Dr. Tom McLaughlin, Pediatrician and Clinical Assistant Professor at the University of British Columbia, and also joining us by video conference Professor Bruce Vercher, Departments of Surgery, Pathology, Laboratory Medicine at the University of British Columbia. Thank you all for taking the time to be with us today. Each of you has up to 5 minutes for an opening statement, and we're going to begin with Dr. Link. Welcome to the committee, Dr. Link. You now have the floor.
Thank you, Mr. Chair, and thank you for having me today to present. I'm speaking on the land and traditional unceded lands of the Mi'kmaq. We are all treaty people, and I know my Department of Pediatrics, the Canadian Pediatric Society, and the Pediatric Chairs of Canada are all committed to advancing the truth and reconciliation recommendations as they apply to children, families, and health.
Excusez-moi, Monsieur le Président.
Chairman, I'm sorry, but the sound is too loud in the room for me to be able to follow. And I'm not really hearing the interpretation in spite of the sound arrangements. It's too loud, the sound in the room, so I can't hear the interpreter.
Okay. Merci, Monsieur.
Thank you, Mr. Thériault. And everyone, I'm very sorry. Perhaps the 2-week break has caused some new problems to pop up, but hopefully that's going to be resolved right away.
Okay, Dr. Link, we're going to get you to restart. I'll reset the clock, and if it comes across too loud in the room, we'll adjust as we go. Please, from the top, if you would. Thank you.
Thank you, Mr. Chair, and I want to thank the committee for inviting me to present today. I'm speaking on the traditional unceded lands of Mi'kma'ki here in Halifax, Nova Scotia. We're all treaty people, and my Department of Pediatrics, the Canadian Pediatric Society, and the Pediatric Chairs of Canada are all committed to advancing the Truth and Reconciliation recommendations as they apply to families, children, youth, and health. I'm going to build my remarks on some of the September 27th presentations that were made to this committee by my colleagues from the Canadian Pediatric Society, the Children's Healthcare Canada, and the Quebec Association of Pediatricians. In addition to my current pediatric leadership roles, I spent 26 years practicing as a community pediatrician on beautiful Cape Breton Island in Nova Scotia, and I had the privilege to serve thousands of children from across the island, from First Nations communities, children with cancer, autism, those who were born prematurely, and dozens of other conditions, and also the 1 in 4 children and families living in poverty there. I'll always remember that there was a family who came to me. They were a young couple, probably in their early 20s. Both have lived lives of adversity and were hard on their luck. And they had a new baby girl, and they brought the baby into my office. And after I had examined the baby and we talked a bit, I asked them, "What do you want for your daughter?" And they said, "We want a better life for her than we've had." And I said, "Okay." And I've thought about that ever since, both as an individual practitioner and as a leader. And obviously, I have to rely on my political colleagues to make some of the big system changes to make that happen. It's quite clear that political discussions around health and healthcare always get mired and confused over jurisdictional issues between the provinces and the federal government, and it will probably always be like that, at least for the next little while. But I thought to myself, if I'm going to present today, if I were a member of parliament or a senator, what are the top 10 things I would focus on if I wanted to try to advance the well-being and health of children and youth here in the country? So that's what I'm going to give you, my top 10 things in pretty quick succession. And you've heard some of them before. One, when it comes to mental health transfers, to commit at least 25% of that representative of the child and youth population to services for child and youth health. We still have too many families and children and youth who cannot access mental health services in a timely fashion. Secondly, and you've heard this from the Canadian Medical Association, and I think there's movement on it, but it's really crucial. The federal government should take the lead on a national health human resources center, and they could collate provincial data on the number, distribution, and mixes of nurses, physicians, mental health workers, allied health workers like lab techs and respiratory technicians, the ages of those health workers, and the number of trainees in various programs. This data would allow for planning to meet the increasing demands of the Canadian population now and in the years to come. We're dropping the ball on this one. We're flying blind. It reminds me of what happened to PPE during the early phases of the pandemic, when the provinces and the feds thought everybody had it in control and we didn't coordinate. This is a major issue. Number 3, I would support the establishment of a national school meals transfer program so that all children in schools receive a healthy breakfast and or lunch without stigma. Currently, about 1 in 5 children, and this is higher for newcomer and Indigenous children, live in relative poverty, and this would be of major benefit. And Senator Rosemary Moody and her colleagues have been trying to advance this, and we would back this. Number 4, and this is a really important one, in 2016, the federal government and Parliament passed the Canada Child Benefit. And I know in Nova Scotia, the year prior to that 2016 date, about 1 in 5 children in Nova Scotia lived in absolute poverty below the market basket measure. In 2019, the last data that I have, that's gone down to just 1 in 9. 1 in 9 is still too many, but almost dropped it in half, and probably most likely because of that Canada Child Benefit. That needs to be index to real inflation. Canada right now, when you look at the UNICEF rankings, we rank 26 out of 38 rich OECD countries in the worst child poverty rates. There's no vaccine for poverty. There's no doctors can't do this. We need everyone to work on this. The United Nations Convention on the Rights of the Child, which Canada passed in 1991, Article 27 ensures that all children should be entitled to adequate standards of living. Are we really living up to that if 1 in 9 children are still living below the absolute poverty line? The other quick point from the Hospital for Sick Children, recently published in the Globe and Mail, was saying that the complexity of the tax forms for poor families and entitled families to apply for some of these measures, it's difficult for some to navigate, and can we make it simpler? Number 5, I would encourage us to pass Bill C-252, which puts restrictions on the advertising of foods high in sugar, fat, and salt to children under the age of 13. Quebec has the lowest incidence of child obesity and children overweight in the country, and they have such a regulations and law. We know if the 1 in 3 children in Canada who are obese or overweight, they have a high risk of going on as young adults and even teenagers to having problems with heart disease, liver disease, and diabetes, and those are significant problems. Number 6, establish a child-friendly national pharmacare program. 1 in 6 families in this country find it difficult and struggle to pay for their children's prescriptions. Also fund a national evidence-based pediatric sensitive formulary that all practitioners in Canada can use. Pardon me. Number 7, prioritize housing, water, health, and educational opportunities for all Indigenous children and health. I've seen some of the benefits of this amongst our First Nations communities in Cape Breton, and when given the opportunity, these children and youth thrive and they blossom and they make huge contributions to our society. Number 8, Canada should continue taking
Dr. Link,
leadership.
can I get you to wrap up? There
Yes.
will be lots of time for questions, and if you just
Sure.
want to make some concluding comments, thanks.
Sure. The final point I would just say, Mr. Chair, is we should establish a national child and youth commissioner in Canada to keep an eye on this issue. We have commissioners for grain and environment and sports integrity. This is really essential. It's been tried before. Senator Moody is still leading this initiative to include Indigenous leadership and communities as well. And I would conclude my remarks. Thank you.
You'll get lots of chance to build on them through the rounds of questions. Thank you very much. Dr. McLaughlin, welcome to the committee. You have the floor.
Thank you, Mr. Chair, for the honor of speaking to the committee. I'm Tom McLaughlin, a clinical assistant professor at the University of British Columbia and a pediatrician at BC Children's Hospital on the inpatient unit, where I take care of some of the sickest and most complex patients in the province. I also lead the Canadian Pediatric Society's work on pharmacare, and I do research and policy work on children's drug insurance, pediatric formulations, and more recently, drug shortages. Clinically, I have the best job in the world. Much like Dr. Link, I get to help children survive illness, thrive, and develop into wonderful people. A big part of how I do that is by prescribing medications. Drugs allow us to easily treat once lethal infections, help kids focus at school, and more recently allow children with rare and devastating illnesses to live and lead better lives. Despite this promise, Canadians struggle to access the drugs that they need. Canada is the only country with universal health care, the only rich country with universal health care without universal drug insurance. Almost 1 in 10 Canadians can't afford prescriptions, and almost 1 million reduce heat or food to afford drugs. This impacts all Canadians, but children face additional barriers to accessing drugs. This is because Canadian policies, largely federal policies governing the development, approval, and reimbursement of drugs, are largely designed for adults. First, children have unique drug needs. Young children often need liquid medications. However, many drugs are only available as tablets. This means that drugs are compounded, where the tab is crushed and mixed with something, either by a pharmacist or a caregiver. Almost 75% of prescriptions for kids are compounded. Might seem trivial to be talking about mixing pills with applesauce on the kitchen table, but this causes real harms. An 8-year-old boy in Mississauga named Andrew died a few years ago from a compounding error, and many more have been harmed by dosing errors. Another unique issue in pediatrics is the prevalence of high-cost drugs for rare diseases. Despite the name, rare diseases are not rare in children. Almost 1 in 10 Canadians has a rare disease, and 70% are children. A second issue is our regulatory system. Health Canada doesn't currently require manufacturers to apply for a pediatric indication or use for a drug, even when studies exist to support pediatric prescribing or where that use is expected, for example, a new antibiotic. And as a result, over 80% of pediatric prescriptions are off-label, meaning they're used in a way that hasn't been rigorously analyzed and approved by Health Canada. Many drugs available in other countries aren't available in Canada at all, requiring importing drugs through our Special Access Program. And even when drugs are approved, they aren't necessarily covered by provincial or federal public drug insurance programs that poor families rely on. Currently, federal agencies, or INES in Quebec, perform an economic analysis on new drugs, comparing their costs and their impact on mortality and quality of life. But for many pediatric conditions, this data just doesn't exist, so this analysis is very limited. It also doesn't capture the economic impacts outside the healthcare system. Treating a child with ADHD medications may help them stay at school and not require expensive educational supports, or it might allow a caregiver to go back to work. The harms of compounding aren't captured in reimbursement recommendations either. All of this means that public drug formularies, the list of covered drugs, can and do exclude important evidence-based drugs for kids. As a result, drug coverage for low-income families who depend on public formularies is extremely variable. In my own unpublished research, I show that children with common conditions like asthma and ADHD may have 100% of their drugs covered, or 0%, up to $1,500 a year, depending on which province they live in. So what can the federal government do? The Canada Pharmacare Act, planned by the end of 2023, promises to ensure universal, comprehensive, and affordable drug access for all Canadians, and it should also address the unique barriers that Canadian kids face accessing needed medications. We should modernize Canada's regulatory system to reduce the need for off-label prescribing and to increase access to safe liquid formulations. We should implement a pediatric rule, as many countries have done, where manufacturers must proactively develop pediatric studies and apply for a pediatric approval when they apply for an adult one. We should support the National Strategy for High-Cost Drugs for Rare Diseases with investment proportional to the disease burden in kids, and support the pipeline for innovative treatments, as I suspect my colleague Dr. Verschere will discuss. We should develop a pan-Canadian evidence-informed pediatric drug formulary, as Dr. Link said, that appropriately values liquid medications and the economic impacts of pediatric drugs outside the healthcare system, and work with provinces to ensure that a child's postal code doesn't impact their coverage for drugs. Children deserve the same access to safe, effective, and available drugs that adults do in Canada, and I hope that this committee can help us get there. Thank you.
Thank you, Dr. McLaughlin. Next, from the University of British Columbia Department of Surgery, Pathology, and Laboratory Medicine by video conference, Dr. Verschere. You have the floor, Dr. Verschere. Welcome to the committee.
Thank you, Mr. Chair. I'm joining you all from Vancouver, where I live and work on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. I'm a diabetes researcher at BC Children's Hospital Research Institute, and I'm grateful for government support of my research through the Canadian Institutes of Health Research and through national networks such as the Stem Cell Network. I'd like to talk to you today about diabetes in children, its huge health burden and impact, the importance of research, and the opportunities we have in Canada as world leaders in diabetes research and care. Diabetes is currently an incurable disease and a tremendous burden on children and families. Children who develop diabetes have it for the rest of their lives. They face a lifetime of checking blood sugars, administering insulin every day, all the while living with fear and danger of low blood sugars. It's a life-changing disease. There are two main forms of diabetes, type 1, in which the insulin-producing cells of the pancreas are destroyed by the immune system, and type 2, a metabolic disease associated with obesity and aging. While one can develop diabetes at any age, children are particularly impacted by type 1 diabetes as it is most commonly diagnosed in children and youth. Canada has one of the highest incidences of type 1 diabetes in the world, and it is increasing in prevalence each year. Type 2 diabetes impacts more than 3 million Canadians and is normally seen in adults, but is disturbingly being found increasingly in youth, associated with the rising prevalence of obesity. This form of the disease disproportionately affects children of certain ethnic groups, including those of South Asian descent, and in particular, Indigenous youth. Because children live with diabetes for many years, they are at high risk for complications later in life, including kidney failure and blindness. Children with diabetes are also at increased risk for mental health problems, including depression and anxiety. The burden to children and to families and to our healthcare system is immense. I have two main messages for you today about addressing the burden of diabetes in children and the important role government can play. First, the implementation and funding for the National Framework for Diabetes, and second, continued support of diabetes research in Canada. First, speaking to Canada's National Diabetes Framework, which was tabled just a few months ago. This is a huge milestone for all people living with diabetes in Canada, including children. I want to acknowledge the vision and effort of those who brought this to reality, including the Health Minister and MP Sonia Sidhu, Chair of the All-Party Diabetes Caucus, and many stakeholders who contributed. The Diabetes Framework provides a strategy for government to improve health outcomes for people with diabetes, including children, through several mechanisms. These include ensuring Canadians have access to resources for disease management, increasing awareness of diabetes for all Canadians, and to fund and promote innovative and impactful research. The National Framework for Diabetes has the potential to have a tremendous impact on the lives of thousands of Canadian children living with diabetes and their family, and I urge the government to ensure that the resources are provided to fund and implement this framework beginning in 2023. Second, I'd like to talk briefly about the importance and promise of diabetes research to children's health. Canada has a truly remarkable research history in diabetes, and Canadian diabetes research has never been stronger. In 2021, we celebrated the 100th anniversary of the discovery of insulin by Banting and Best, a miraculous Canadian medical research discovery that allowed children with type 1 diabetes to live long lives. But even Sir Frederick Banting said that insulin is not a cure for type 1 diabetes. More research is still needed. Since the discovery of insulin, Canadian diabetes researchers have made pioneering contributions, including development of drugs in common use today for type 2 diabetes and weight loss, pancreatic islet cell transplantation in type 1 diabetes, and more recently in stem cell-based therapies for type 1 diabetes. It is important to point out that the development of these therapies were built upon foundational research and took many years to move from discovery in the lab to the clinic. Tri-Council funding, particularly CIHR, ensures that the best diabetes research is funded across the country. The diabetes research capacity in Canada remains strong, and that new discoveries will find their way into new therapies. In 2021, the Canadian government invested in diabetes research through the CIHR Institute of Nutrition, Metabolism, and Diabetes, in partnership with other funders, including the JDRF, Stem Cell Network, and Diabetes Canada. This investment has had a transformative impact on diabetes research in Canada, including the creation of national teams and networks working together to understand the cause of diabetes and find new treatments. I feel it's important that the momentum built by these national diabetes research teams not be lost, and I urge government to continue to support diabetes research through these special initiatives and innovative partnerships while maintaining and increasing Tri-Council funding for foundational research. To conclude, diabetes is a life-changing disease and a tremendous health burden affecting thousands of Canadian children. And I encourage government through implementation and funding of the National Diabetes Framework and increased research funding to continue to address this significant child health issue. Thank you for allowing me to speak to you this morning or this afternoon, and I'm happy to answer any questions.
Vercher, we're going to begin with rounds of questions now, starting with the Conservatives. Dr. Ellis for 6 minutes.
Thank you, Chair, and thank you to the witnesses for being here today. As you all may or may not know, we are coming close to the end of our study on children's health, which has become very large, and as all of you pointed out, it's a very complex topic in terms of the breadth and the actual numbers of things that can influence children's health. Anyway, that being said, Dr. Link, I'll start with you, if I could, through you, Chair. You talked a bit about mental health transfers and 25% of those transfers coming to children, and certainly that's been part of our difficulty. The Canada Mental Health Transfer has not been forthcoming from this government, even though promised, but that's a whole other kettle of fish. Maybe you could talk a little bit, if you would, about resiliency in kids, and is there an opportunity to speak about that in the educational system as well?
Yeah, that's a great point. I mean, and mental health care is just one aspect of mental health. Obviously, families that are functioning well, schools that are functioning well, and all those support systems are really important too. UNICEF does a very good job. If you look at their 2020 report card for Canada, they had about 125 different indicators, and they measure some of these specific things around resiliency and how kids are doing. And I was a little shocked, actually. A quarter of children are feeling sadness or hopelessness for long periods of time. Only 50% rate their lives high on life satisfaction, and a quarter of kids go to bed or school hungry at least sometimes because of lack of household food. They go through all of those different things. So if I'm understanding your question right, Dr. Ellis, resilience is more than just healthcare. It's the family income. It's how well you're supported at school. It's how well communities function. It's about the environment. It's complicated, obviously, but that's why I think I was trying to make sure, at least if there were mental health transfers going to the provinces, that the provinces should be accountable to make sure that some of that money is dedicated to child and youth services. And with that, and I agree with the current government that provinces are responsible if they're going to get the money. I think they need to publish outcomes and wait times and how people are doing. And that's a wonderful opportunity for us to compare between provinces, because provinces that are doing better, and most provinces are doing better in something than other provinces for various reasons, it's an opportunity to learn and to share and scale things up. So I don't know if I've answered your question completely, but you're right. Resilience is important, and it's supported in many different ways.
Thank you very much, Dr. Lincoln. And through you, Chair, to Dr. McLaughlin, you talked a little bit about children's medications. And I'll just focus on that. There's another topic I will come back to later, perhaps, or if we have time. But certainly when you look at the drugshortages.ca website, we still understand that children's Tylenol, children's ibuprofen is short, and in my estimation, every first-line antibiotic that would be given orally to children is also in short supply in Canada. I was wondering if you had any comment on that, and have we seen this before, and do you have any ideas around the solutions?
Thank you very much. That's an excellent question. Now, you're right. Drug shortages actually have existed for beyond this current round of specifically pediatric shortages. And that relates to some of those regulatory issues that I talked about. There are many drugs where they're not widely available in Canada, and so through our special access program, we essentially sort of import and do one-off importation for them as a routine matter. And that is something that continues to this day. It has been worsened by the pandemic in terms of common children's medications like Tylenol and Advil and antibiotics. And I think it gets back to, in large part, what I was talking about related to regulation. I think we struggle with having child-friendly drugs available in Canada because our regulatory system doesn't push manufacturers or support manufacturers to have those drugs be widely available. And so there's more we can do on that through incentives and through mandates to be applying for needed drugs.
And thank you very much for that. And through you, Chair, once more, you talked a little bit tiny bit about rare diseases, and certainly we know very clearly that Canada is the only G7 country that doesn't have a rare disease strategy, which disproportionately affects children. And I'm wondering if you might comment, it's probably not exactly in your area of expertise, but if you have some comments around rare diseases and the definition and how you think Canada might proceed with a rare disease strategy.
Yes, and I think the reality is that as pediatrics, the field has evolved. We have largely become a specialty of rare diseases. At my hospital, I work on the inpatient ward, so it's the tertiary referral center for the province of British Columbia. A quarter to a third of all patient beds are filled by a child with a rare disease. So clinically, this is in every pediatrician's wheelhouse. And I agree. I think we do need to have dedicated leadership. This is a role where the federal government can serve an important coordinating role, as is done in many other areas of healthcare. So we really should have a national strategy for rare diseases, and that should involve work on our drug development pipeline, on our regulatory system, and on how to best support and reimburse these medications that can be very expensive. So certainly agree that we need a national strategy.
Thank you, Dr. McLaughlin. Dr. Ellis. Next, Mr. Van Koeverden, please, for 6 minutes.
Thanks very much, Mr. Chair, and thank you to the witnesses for coming today. Your testimony has been very, very interesting, will be valuable in producing a report to Parliament on children's health. Dr. Link, you started listing your top 10 priorities, but I think you only got through about 8. So before I ask a question, I'd provide you with an opportunity to list the other 2, because I was taking notes and my list is incomplete.
I appreciate that, and I did submit my notes, and the other 2 that I didn't get in, I'm sorry, I maybe should have cut it down to 8, but the other 2 were Canada. We need to continue to take a leadership role in global climate change and greenhouse gases, because if we don't address that one, the next generations are going to be in big trouble, I think. And secondly, was to, and back in what Dr. Verschuur has been talking about, invest in health research, keeping an eye on those budgets. Canada has a stellar record of contributing globally to new innovation, new knowledge that is actionable, that makes a difference in people's lives. And through our CIHR, and specifically there's an Institute of Human Development, Child and Youth Health, just make sure that we're well funded so we can support some of the world's best scientific minds and also mentor the next generation of clinician scientists. I just remember being in Cape Breton looking after kids with cancer who, when I started as a medical student, would have died, had a high chance of dying. And by the time I started practicing and well into my first decade, these kids had sometimes 90% survival rates. And that's all because of clinical trials, research, same about diabetes, to Dr. Verschuur's point, all the new tools that we have. That's because people are doing research to help us as a healthcare community. So those were the other 2 things I just wanted to mention.
Thanks. It's a really good list, and there's a couple that stand out to me. Current work of this committee around marketing to kids and a National Child and Youth Commissioner is one that has been spoken about at this committee from Healthcare for Children as well. So I thank you for underscoring them, and I think I'd say it's a very, very comprehensive list of suggestions. Over to Dr. McLaughlin. We talked a little bit about rare diseases, and February 28th was Rare Disease Advocacy Day. I used to participate with a friend named Simon Eibel, who started something called Be Fair to Rare, and got me thinking more about rare disease advocacy prior to being a politician. And I just want to, I think I've mentioned him before on this committee, but he's a special guy who left us too soon, and his work was really, really exceptional. I'm wondering to what degree you've been engaged on Canada's rare disease strategy and rare disease drug strategy. I spoke at the CORD conference last year and had an opportunity to hear from advocates directly, and they were they had mentioned that the work is ongoing and it's complicated, obviously, because it's so far-reaching. But any comments that you have on Canada's future rare disease strategy as it pertains to drugs or treatment?
Thank you. That's an excellent question, and I think, you know, the future of drugs, the future of pediatric drugs, is going to be something we will all have to grapple with, and it's in the name. These are expensive drugs for rare diseases. By and large, these are drugs for a very small population. It is relatively difficult to get high-quality evidence in the way that we used to do it through randomized control trials and that sort of thing, and so we often have imperfect evidence as part of our development strategy, and then that also impacts reimbursement. Should we be paying $100,000, $1 million, $2 million for medication for a child with a significant rare disease? And I think it's important to balance lots of different things. The magnitude of the disease matters. I think that if it is a child where their life is threatened, then I think that it makes sense to have more focused and specific endpoints that might actually be about that child. It might be that we cover a drug and then we actually monitor that child's symptoms, and we need to develop that evidence infrastructure on how to follow evidence for a very small population. And that also impacts reimbursement decisions. Again, I mean, you know, our current system, CADTH and NES, do account for patient perspectives and for the magnitude of diseases, and I think that needs to be further fleshed out. And then at a federal level and at a governmental level, you know, there's lots of dollars involved. What amount of funding should we be supporting this with? And I would say this is something that should be commensurate with the disease burden. So I think all of those things should be part of a rare disease strategy, and I would encourage everyone to look up CORD and other national advocacy organizations who have very fleshed out positions on this.
Thanks, Dr. McLaughlin. Yeah, CORD's an awesome organization. We should maybe consider adding them to the list of witnesses. You mentioned the cost of drugs for rare diseases. I think your average Canadian feels that pharmaceutical companies they sense this like degree of discompassionate kind of profiteering when it comes to the lives of kids. Do you have any insight as to how or why these drugs, which are so critical in I think of a couple of kids in my riding. Statistically, there shouldn't be more than one, but there's more than one case of spinal muscular atrophy in Milton, and the cost of those drugs was completely inaccessible, like more than any family could afford, virtually. And working through the sort of rigmarole, I think it was I forget the name of the drug because I'm thinking of the cystic fibrosis one, Trikafta, which was Spinraza. Spinraza, thank you. Do you have any insight as to how these drugs get so completely unaffordable and what role the government can have in maybe leveling that playing field or making them a little bit more accessible?
Succinctly as you can, Dr. McLaughlin, if possible. We're out of time here.
Of course. I think any profit-making company's motivation is to make profit, and that's a good thing. That's how societies become wealthy and develop innovation. And then it's on us as a society and as governments in particular to balance that with appropriate regulation and controls on those prices. And so I think it is a very important government role to be involved in how much drugs cost and what their prices are.
Well done. Thank you. Mr. Thériault pour 6 minutes.
Mr. Thériault for 6 minutes. Thank you. Thank you, Chair. First of all, it's really exciting to listen to these very interesting contributions. I think we could have discussions with you, Dr. McLaughlin, for an hour, but I'll try and go quickly. I'll start with Dr. Link. You've mentioned 10 different solutions or 10 different areas of work to improve children's health. And without going into the question of competence and jurisdiction, I understand all of that. But are you telling us that children's health has a brake put on it because of the way that health is organized, because of the federal and political organization structure? Because it seems that you were talking about breakfast, and in Quebec, it's on a universal footing, this practice already. So what were you driving at when you've said that we shouldn't get concerned about all this? I'm just launching my ideas, but afterwards we need to sort this out between the different levels of jurisdiction. So is it the federal organization which is putting a brake on children's health?
Merci beaucoup. It's a very good question. I think one of the most startling examples of where children fall through the cracks would be our Indigenous children when they need special services and who pays for it. And there was something a few years back, people will recall, called Jordan's Principle, where the children would get the services and we could fight over whether the feds or the provinces pay for it first. But there was a lot of red tape, and one child by the name of Jordan passed away prematurely because there was jurisdictional battles over who was going to pay for his complex care. So that stuff can't happen anymore. We need to sort things like that out. And clearly, the provinces have a lot to do with the social and health well-being. They run schools, they run hospitals, they run clinics, they run the roads, they do a lot of environmental things. But my point is that what is clearly in the federal wheelhouse, and that's why I've listed these 10 different ideas that if I were a member of Parliament, that's what I would focus on. If I were a member of the Nova Scotia Legislative Assembly, I might focus on some different areas that were within the provincial jurisdiction. And to keep our focus on things federally, to share best practices, best evidence from across the globe, so Canada is the best place to raise a child. That's why I was finishing and highlighting the need for a national child and youth commission or commissioner in concert with our Indigenous leaders as well, to keep a focus. There's so many things, as you know, as MPs, that you have to deal with, and so many national issues of importance. But I just don't want this to get lost, and that's where that national commission or commission can help keep us focused on this important issue and share best practices from different provinces and different jurisdictions.
In Quebec, there are programs that already exist that you've mentioned. Some of these solutions you've mentioned are already set up. Basically, it seems that you're saying that practitioners have to be able to share their best practices, and the federal government should facilitate these exchanges of best practices. I imagine that's what you're getting at. And having a National Children and Youth Commissioner, we already have the equivalent to that in Quebec. And then saying that 25% of mental health transfers for youth, that's all fine and well. But if we look at what's been put on the table lately by the government, which is totally insufficient, how can we do all of this? Everyone who comes before us here, sorry to use English, but they want to have a tag for investment for their specific domain of expertise. So how do we decide between all these different demands?
It's an excellent question. And I think one of the things that we need to do a better job is measuring outcomes. You know, there's a lot of data across the country on wait times for adults waiting to receive knees and hips and cataract surgeries, very little on children. We're starting to establish some wait times for surgery, for example, but how well do we focus on outcomes in terms of resilience, well-being, access to services for children across the country? Again, that's where a national commissioner can collate that data. And if Quebec, for example, or PEI are doing really well in one area, why is that? Why are your obesity rates lower? Why are your diabetics complications lower? Why are your surgical wait times for children lower? Why are children doing better in school in your particular area? There's all sorts of things to share, but I don't think we have one area and one group who's bringing this all together to help you folks who are going to design policy, legislation, and budgets to really make informed decisions, especially with competing priorities with an aging population, with all sorts of external threats to Canada and other things. That's why I'm.
Dernière question. Est-ce que
Last question. Do you consider that there's enough investment in research being paid for by the federal government when it comes to pediatric research? Do you not think that we need to do more catch-up on that?
Yes, I agree with that. And Dr. Verschure may also want to jump in on that. But my faculty here at the Department of Pediatrics in Halifax, we have about a 12% success rate when we're applying for research funding. And I can tell you, maybe that's getting the creme de la creme, but there's probably another 20 or 30% of people who aren't getting funded who have excellent ideas and things that will make a difference in people's lives because there's not enough money. There's a cutoff line. And I realize in life there have to be cutoff lines. But is a 12% acceptance rate good enough? I don't think so. I think we could invest better in that as well, and that's an important investment for the future.
Thank you, Dr. Link. Mr. Theriault. Mr. Davies, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses for being here today. Particularly pleased to see two from British Columbia. Dr. McLaughlin, I would like to start with you. Are there socioeconomic barriers facing Canadian children in accessing affordable medications?
Yes, definitely. Medication access is something that varies immensely between provinces and jurisdictions, and this is particularly important for families living in poverty. And depending on what province you live in, you might have almost all of your children's drug costs covered, or you might have to pay out of pocket even if you are below the poverty line.
Now, do you see actual cases in your practice of kids who show up in who can't afford medication or maybe even in hospital because they haven't had access to medication?
Oh, yes. I work on an inpatient ward predominantly, and it's not an entirely infrequent situation when we will prescribe a medicine for when the child goes home. In hospital, all drugs are paid for by the hospital, so patients are not bearing costs. I'll prescribe a medicine, and then an hour or a day later, the ward will get a call back when the parent is surprised to see what it costs. And they'll sometimes say, I can't afford this. I need a different medication. That really does happen, yes.
Thank you. I'm going to come back to you. Dr. Verschoor, I want to kind of ask you the same question. Do you see any socioeconomic disparities? I was going to say an insulin uptake, but I would expand that to glucose monitors, test strips, syringes, pumps. Is there restricted access to those dependent on income disparities in Canada in your experience?
Yeah, the answer to that is yes. Thanks for the question, MP Davis. So that's left to the provinces. Insulin's largely covered, but devices, if you're looking at a pump or continuous glucose monitoring, that can be $7,000 to $8,000 out of pocket. Depends on the province that you're in for the coverage, and then a few $100s per month. And of course, that means that access to these devices, which we know have an impact on health because they improve control, they relieve the stress of the disease, they reduce complications because the glucose control is better. And because not everyone can afford that out-of-pocket cost, there's definitely a socioeconomic disparity in access to that.
Thank you. Dr. McLaughlin, in 2020, you co-authored a position statement for the Canadian Pediatric Society titled Pharmacare in Canada, the Pediatric Perspective, and you included a recommendation, I'm going to quote, federal, provincial, and territorial governments should develop and implement pharmacare plans that mandate universal, comprehensive, portable prescription drug coverage for children and youth. Now, this committee, not in this forum, but the Health Committee in 2017, and the Hoskins Advisory Committee appointed by Prime Minister Trudeau in 2019, both recommended exactly that via a single-payer system. In other words, expanding the basket of covered services in our single-payer system to include essential prescription medicines. Do you agree with that recommendation?
Thank you. A single-payer system would certainly be the simplest way to have the federal government serve the same coordinating role as it does in other areas of healthcare. And that would still mean that provinces have jurisdictions and are responsible for delivery of healthcare, including prescription drugs. There are other options. We have a patchwork system. We can have more patches, and that would probably marginally improve the situation. In Quebec, there's been mandatory insurance, which is subsidized. So there are different ways of getting there, but I think we should all and probably do all agree that children should be able to get the drugs that they need and not have to be facing cost barriers.
Dr. Verschoor, I want to ask you about the connection between healthy diet, sugar consumption, and other things. I understand that's probably more of a type 2 diabetes question, but there's currently legislation proposals before Parliament to restrict marketing of poor nutritional items to children, sugary beverages, etc. There's a proposal, both the Liberals and the NDP in the last election ran on devoting $1 billion over 4 and 5 years to establishing a school nutrition program. I'm wondering if you could give us your position on the connection between nutrition and the development of diabetes.
Yeah, thank you for the question, MP Davies. So you're correct in that type 1 diabetes has a different etiology, but certainly in terms of type 2 diabetes, we know that diet is an important contributor. There's a genetic and an environmental component to type 2 diabetes, and both sedentary lifestyle and an unhealthy diet contributes to obesity and risk of type 2 diabetes. And it is increasing in prevalence in kids, particularly in certain ethnic groups and certainly in Indigenous persons. So I do think that measures that would lead to healthier food intake and food choices and food security could have an impact on the incidence. And I should point out too that many kids who are obese and haven't perhaps developed full type 2 diabetes are at very high risk for developing type 2 diabetes early in their adult life. So the impact of that in children, I think, is really important, the potential impact.
Dr. McLaughlin, we all saw the shortage of pediatric pain medication that occurred this fall. I think this committee heard evidence that there are literally hundreds of drugs that achieve shortage capacity every year. So we've got a problem with drug shortages in this country. Specifically, what steps do you recommend the federal government to take to help address shortages of pediatric medication?
Briefly, if possible, Doctor.
Thank you. And I think in particular with many of the pediatric medications we're talking about shortages of child-friendly liquid formulations. There's actually lots of Tylenol out there. It's just that it's tablets. And it's hard when you're a parent at 2 a.m. to be responsible for the last step in the manufacturing process. That has errors and has dangers. So I think it, again, goes back to the regulatory issues that I talk about to support and incentivize manufacturers to have child-friendly formulations available in Canada. And there's a number of steps to get there.
Thank you, Mr. Davies. Dr. McLaughlin. Next, Ms. Goodrich, please, for 5 minutes.
Thank you, and thank you to all the witnesses. I think that's a good place to jump off on. As a mom, I was actually the first person to bring forward the idea of the Tylenol shortages and the liquid formulations. Because I remember just feeling crazy. I thought I was crazy, I thought I was alone, and that it was just an issue that I was seeing. And then I've come to learn that this is something that happens with a lot of children's pieces, and I'm not sure if it's that we don't have all of the right regulations in place or that we're not putting enough emphasis on this, but one of the most alarming pieces that's been brought to my attention in the last few weeks that's resurfaced is the shortage of baby formulas. And we're seeing this coast to coast to coast where parents are struggling on going onto social media platforms just to try and find basic food to feed their child. I was wondering if you could comment on how important having adequate access to pediatric formula would be.
Yes, thank you. It's an excellent question. I'm also a parent, and can certainly relate to what you're talking about. Now, I'm not an expert in formula regulation and availability, but certainly I can say that formula for many children who can't breastfeed or where parents choose not to is a key form of nutrition. And for some children who require specialized formulas because of intolerance to proteins, in particular, there can be difficult access to that. I suspect that there are similar availability and regulatory issues, but I would have to look into that and get back to you.
Well, I appreciate that, and I know that it's something that's challenging, and I went back onto the Health Canada website here today to do more research because it's been brought up that this is missing yet again, and there is a big piece on breastfeeding. And while I think many do acknowledge that breastfeeding is a very good option and is the natural option, it's not an option that works for everybody, and not everyone can, and not every baby can have breast milk, and so when these kinds of pieces aren't available, it just adds a lot of extra stress onto the parent, which intrinsically puts it on the child. You were talking a little bit about how the adult formula of Tylenol wasn't available, and that midnight trying to get your kid to eat it. And I know I've struggled to get my son to have any children's medication that's not grape flavored. Cherry flavored gets spit in my face. And I'm just wondering if you could expand a little bit on some of the other oral medications that children's medication is shortage.
Yes, thank you. And you're absolutely right regarding feeding. I think that breastfeeding does have unique benefits. That should not mean that mothers in particular should face an additional burden or expectation as they are already facing the hardest job in the world. I know that my wife went back to work at 2 months when our son was born and had difficulty with pumping, and so we used formula, and I'm totally okay with that. Now, in terms of drug shortages, I think that there's different pieces to it. I think with the pain medication, we're talking about shortages of drugs that are generally available and were acutely not available. There's also many drugs that are just never available in child-friendly formulations. There's a list from the Goodman Center in Montreal that has sort of 20 drugs that are available in other countries that are commercially made liquid formulations and are not available in Canada because they just haven't been applied for by their drug maker. This includes a key epilepsy drug, and it includes many others. And so it's a mix of availability of products that are generally available, which does happen, and that has been shortages recently. It's also products that are not available at all in child-friendly formulations and might be available in other countries. And then there are drugs where there isn't a pediatric formulation in any country. I mean, for some of our HIV medications, if you have an infant who's born with HIV, we laugh about not taking grape-flavored medicines, but these medicines are important. If you have to take a medicine every day if your infant has to do that in order to not develop resistant strains of HIV, that is serious business. And these medications can be extremely unpalatable because they're not available. And as a result, some children can develop drug resistance to that. And so that is something that does happen. And so there's actually several different layers of having the right medications for children, including some that you touched on.
Well, thank you. I appreciate that. And sorry I didn't get to ask questions to any of the other presenters.
Next up, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses, for your valuable testimony. My question is to Dr. Verschoor. Dr. Verschoor, I saw the firsthand the Diabetes Excellence Hub and Diabetes Research Program at the Child and Family Research Institute. Thank you, the work you are doing on that. Can you tell us about the Mini Med School initiative and how it is encouraging and promoting science outreach and education? I know you have a different topic every month to engage youth. Can you elaborate on that?
Yeah, I'd be happy to. Thanks for the question, MP Sidhu. So where I work, and Dr. McLaughlin too, at the BC Children's Hospital Research Institute, we have a unique program to try to bring science and research and medical research, pediatric research really, to budding young scientists, to encourage high school students of all backgrounds to consider careers in research. And to do that twice a year, we host a mini med school. It's usually around one topic. We've done diabetes 3 times, and it's held over 6 consecutive evening over a month and a half. And it reaches, when we do it in person, about 250 students come into the hospital. They learn with some lectures and hands-on work with our pediatricians, our scientists at BC Children's Hospital. Interestingly, during the pandemic, when we went virtually, we were even able to expand our RIS because we wanted to reach other parts of BC, and people find it hard. It's hard for them to come down to the Lower Mainland. And the results of that have been really remarkable. I should say the mini med school spans from cancer, transplantation, immunology, infectious disease, mental health, diabetes. We've had high school students come back from that program, become summer students, and a few have even gone on to do PhDs in medical school. The program's been in place for some 20 years now, and have even come back to do further research training at the Institute as PhD students and postdocs. So it's been, I think, a remarkable success, and I would love to see it happen elsewhere in the country.
Thank you. And to follow-up questions, I know this month is a nutrition month. Nutrition and active lifestyle play a big role in prevention of diabetes. What are the most promising area of research in childhood diabetes, and how might they lead to a new treatment and therapies? Can you tell us?
Yeah, it's a really exciting time in diabetes research. When we talk about childhood diabetes, we're usually talking about type 1, although, as I've said, there is an increasing prevalence of type 2. I think most exciting is just we have access to such incredible technologies in regenerative medicine, in stem cell biology, in gene editing. And so one area of research, which has a great Canadian story that's gone from the laboratory to clinical trial, is in the transplantation of insulin-producing cells into people with type 1 diabetes that started with pancreatic islet transplantation in Edmonton, has gone from our ability now, and some of this work was done at UBC, in being able to make insulin-producing cells from stem cells, and now that's in clinical trials in adults with type 1 diabetes with sites in Edmonton and Vancouver. I think a big issue for us is that we really want to see some of these therapies be able to be given to children, and there's issues with that. For example, with stem cell therapies, the recipients still need immune suppression, and so ethically we're just not in a position to do that with kids who need more safety studies. But this is a really very promising area of research that looks like it could lead to people with type 1 diabetes being insulin-free. I'm not sure I would call it a cure, maybe a functional cure. They will still need to take immunosuppressive drugs, but it's would give them better sugar control and potentially be free of insulin.
And lastly, what role can community-based organization and advocacy group play in supporting families and raising awareness about childhood diabetes and how we can prevent that?
Yeah, this is a really important, I think, what I've learned, and I think this has been, mandated by CIHR funding, is that we have an element of patient engagement where we interact with persons with lived experience with diabetes, with our funded investigators and our trainees. So we've had a lot more interaction with people in the community, both with type 1 diabetes and type 2 diabetes. That's inspired and helped instruct our research and how we communicate it. But I think really importantly, it's critical that we get out to the community, particularly those who are in lifestyle intervention research, especially people who may not live, for example, in BC in the Lower Mainland, in more remote areas, just to learn about diabetes awareness, about the potential impact of effective diet and lifestyle. So we could do much more there, and I think the research is showing that it works. One example is our BC Diabetes Research Network, which we formed, now has a van that allows us to go out into the community and interact with groups, for example, in Surrey and the South Asian community. We're hoping to do more of that.
Thank you, Ms. Sidhu, Dr. Verschere. Next, suite de M. Thériault pour 2 minutes et demie.
Mr. Thériault for 2.5 minutes. Thank you, Chair. Dr. Link, you talked about socioeconomic determinants. Our health system was vulnerable before the pandemic. Several people said that the pandemic has actually exacerbated these health issues related to children's health. My grandmother said it's better to prevent than to cure, and with prevention you need education. At the moment before the pandemic, where we were told that we were living in a system that was very fragile, it was very hard even back then to respond to demand. So we're basing ourselves on emergency medicine, and we deal with the most urgent cases. So it's very difficult to actually come out high on the UNICEF report. With the UNICEF report, we'd need to invest more in prevention if we want to climb up the ranks. We talk about child mortality, obesity, immunization, and that we're in the lower third, even though we're a rich country. Do you believe that what's been put on the table so far in terms of health transfers is actually sufficient for the next decade? Is it sufficient so that we can move away from emergency-based medicine to actually move towards prevention, which really is the key in order to get our healthcare system back on its feet?
It's an excellent question. There's probably never enough dollars for healthcare or health compared to all the other competing priorities that we have in governments, I'm sure. I would, and I'm conflicted sometimes as a pediatrician, and I have a child like Dr. McLaughlin. I also work on the wards with children with rare diseases who the drugs cost can be enormous. And for one family versus that same money going to helping children who are living in poverty, like how do you make those decisions? It's not easy, that's for sure. And they're both deserving. I would add also that when my colleague Dr. Verschere is talking about diabetes and prevention and control for type 2 diabetes, obesity is a major contributing factor, and more children who are living in poverty have problems with their weight because the foods they can afford to buy are usually high in carbs, and they can't afford healthy foods, and they often can't afford to participate in healthy activities like sports teams and things. So to me, poverty is at the root of a lot of our issues, the social determinants of health. And the federal government has made a big contribution to that in the last 5 years. And the provinces and the feds have to continue to do that. So those 1 in 10 kids living in families below the absolute poverty line are given a hand up. That will go a long way in settling not everything, but a lot of things, I think, when it comes to our health. The other thing I would just say is that you mentioned education. There's a tremendous opportunity to share best education practices across the country. Learning to read, the Ontario government just had a Right to Read program, and they're using new evidence-based methodologies to teach kids to read. 1 in 3 kids in Nova Scotia are below standards, and probably in many other provinces by the time they're in grade 3 or 6 because we're using old methods. There's so many good things that contribute to health and resilience and children having the best shot that we can share across this country. And again, I would just focus us in. We need one group or somebody to be able to bring this all together to advise the feds and the provinces on best policies that we can share and measure outcomes and do better and make Canada the best place to raise kids.
Thank you, Dr. Link. Mr. Davies, please, for 2.5 minutes.
Mr. Davies changed for Mr. Boulris.
Boulris, je m'excuse.
Sorry about that. You have 2.5 minutes. Thank you, Chair. Dr. McLaughlin, I'd like to hear from you as a paediatrician because in Montreal at the end of last year, there was a real crisis in the emergency department at Sainte-Justine Children's Hospital. There was a resurgence of child respiratory illnesses that were really virulent at the end of the year. And I learned that it was also a consequence of the pandemic because many children had not really developed their immune system because they'd been isolated for several months or even several years. So when do you think that we'll be able to get back to a normal situation for our children's immune system, or will this last over time as a phenomenon?
I think that's a fantastic question, and I don't know that I or anyone has the answer to it. I think if I've learned anything, and we've learned anything from the last several years of the pandemic, it's that making predictions about what's going to come next are hard to do. I agree. We all face the same crisis in our children's hospitals, and that was related to not having exposure to viral illnesses. How that will play out over the coming years, I think, remains to be seen.
Okay. Je voudrais
I'd like to put a question to Mr. Link, because we were talking about socioeconomic conditions and socioeconomic determinants of health for our children. You've talked about poverty and education. Could you talk about the quality of housing, please?
That's also one of the major determinants of health. So it's not just your postal code, your genetic code, it's your postal code that is so important. And there are a lot of families that are living housing insecure, and especially with in a lot of cities across the country, rents are going up, and it's a big issue. And I would just say that all of those issues around poverty, and as someone I haven't lived in poverty, but I certainly deal with families every day with that, the stress that puts on parents and what that causes between partners, between parents within families, contributing to discord, conflict, that whole stress. We know that children who are raised in stressful households, especially as young children, that actually affects how their genetic code gets expressed and probably brain development when they're living under constant stress and pressure. So you can imagine if there's not enough food in the house, if there's not money for winter jackets or for rent, that stress is huge. So I'm just going to go back again. I mean, poverty to me is one of the root causes of a lot of issues that both the federal government has done something about and can contribute to do something about, as can the provinces. We need a strategy. We need targets. We need outcomes. It's not acceptable that 1 in 10 children are living below the poverty line in this country. Not at all.
Thank you, Dr. Link. Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and thank you all for being here, and congratulations on your hard work in becoming pediatricians. I know the big challenges for all of you to the hours that you put into to just get to that stage, so I appreciate that. My wife was a pediatric intensive care nurse at the Hospital of Sick Children, and we got to know a good friend, Dr. Tony Addison, who's a pediatrician, who delivered our first 2 children, and unfortunately then we moved to rural Saskatchewan, and we weren't as, but with that said, the doctor we had was a fantastic doctor at the time. And that's a big challenge that a lot of Canadians have. Because they don't have access to pediatricians, and they don't have that benefit to get that education and that knowledge from the mindset that you have and what you can provide to that. And so I want to try and give a very quick question without getting too long-winded answers. But the reality is, how do we educate Canadians? You know, how is it, you know, when I look back to Participation, they put out the advertisement of 70-year-old Canadian, get out and exercise. That was a fantastic ad. So how do we do that to Canadians to say, you know what, get that best evidence out there, best practices education, so that Canadians understand how to look after the children so they're not running and clogging up our emergency wards because of things that maybe they could possibly do at home. I'll start with you, Dr. McLaughlin, if I can.
Yes, thank you. That's a very good question, and I agree. In particular, for folks who don't have easy access to subspecialists or to specialists like pediatricians, I think it can be particularly challenging to get good, high-quality information. I do think that governments can have a role in ensuring that information is available. I think, you know, specifically to emergency departments as well, I think that relates to having a really strong primary care system and having other options other than emergency departments. I know in British Columbia, we've actually developed a virtual pediatrician on-call system where anyone in a family doctor's office, a nursing station, anywhere can actually contact a pediatrician and they can speak directly to a family. That's called Charlie, which is an acronym. And so I think there's lots of different things. And then the final thing I'll say is we should ask Canadians and we should work with Canadians. What is the best way to get information? I'm in the ivory tower and I certainly have my ideas. And I think some of them are good, but I think we should also be engaging with people. How do you get information? How can we meet you where you're at?
Thank you. And Dr. Links, I'm going to ask you the same thing, but before I'm going to throw another question at you quickly that you might want to touch on. And it actually, if you can answer that one, but you also mentioned your number 2 point was on the National Health Human Resource Center collection of data. And I'm interested to hear a little bit more about that on data on practitioners. I recognize that my wife is now retired, and many practitioners with COVID have basically felt that they got burned out, and so a lot of them have retired at this point in time. How do we get that set up?
Those are both great questions. I would just say the Canadian Pediatric Society has a wonderful website called Caring for Kids that is written for families, basic levels, that has all sorts of wonderful information. So I'm just going to put that plug in that some of that information is out there. We also have to contend with a lot of misinformation and disinformation around vaccines and other things, and that's another huge issue. To the health human resource issue, it's huge, and we've really, in the pandemic, exacerbated everything. You know, in a lot of pediatric departments, I can just speak for pediatrics across the country, maybe a third of the pediatric health workforce are doing okay, a third are doing so-so, and a third are struggling, you know, with their own well-being, feeling burnt out, often because they don't have enough colleagues and supports to help them, and the moral distress of knowing you have long wait times and you can't do all you want to do for your patients. The big thing is planning. Are we going to be in the same position 5 or 10 years from now? Again, we're flying blind right now. We don't know. How many pediatric neurologists do we need in the next 5 or 10 years? I can't even answer that. And I was president of the Pediatric Chairs of Canada because I don't have that data readily at my fingertips to plan. And how many should we be producing? Who might be retiring? Who's thinking about that? So this is where I think the federal government, on the advice of the Canadian Medical Association, the Canadian Nursing Association, others, can have a center to really collate all this information and help us plan so we don't get burnt on this again.
Very briefly, go ahead. Yep.
Thank you. And Dr. Verschere, not to leave you out, I just very quickly, on the issue of T1D, and in particular, just the high costs of some of the medications we look at. And for example, I'm going to use Jardiance as an example, which has been really looked at from a point of view of kidney failure. And in fact, you probably are aware that they've discontinued the research on it because of the great evidence they've seen on it. That's a huge cost to families in utilizing the value of that medication. I'm just wondering on your comments on that aspect, if you would, please.
Yeah, well, I'll preface it by saying I'm not a clinician, so the pediatricians here on the call may be better equipped. But, I think it's an interesting class of drugs. Like they lower blood sugar quite effectively, and there's clinical trials have shown improvements in kidney and cardiovascular disease, alleviating those complications of the disease. I think it just speaks to the importance of research and the need for clinical trials, right? And partnering with pharma on these trials, because eventually, evidence will drive the decisions that we make around drugs. I think there are still members of that class of drugs that are still being used and are thought to be safe. But I think, there's always, with any drug, there's concerns of side effects, and it's always a balance.
Thank you, Dr. Verschere. The final rounds of questions for today's meeting will come from Mr. Joe Harry, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses for your testimony. Today, it was very insightful. I'm going to focus my line of questioning really on data, and I'm going to start with Dr. Link. Dr. Link, a number of times, whether it was in your opening remark when you talked about the National Health Human Resource data, as well recently as you responded to my colleague Dr. Kitchen's question on a planning tool, where you would be able to see where the supply is, what's the situation of supply, and where the demand in the future is going to be, as well as when you were responding to the role that the National Youth Commission or commissioner can take in using data to be able to look at jurisdiction where they're doing producing some really good results and be able to compare it. So can you expand on where you see the data for children health should come from? I really like to get an understanding of, if you're going to develop a children health data strategy, who should be developing it, what should be the element of that strategy, who should be monitoring it, what jurisdiction needs to collaborate together to be able to collect that data, and how that data would be able to help us form the policy that we need in the future.
It's a great question, and I'm not sure. I think we all agree that we need to measure things. What gets counted counts, right? And we need to measure outcomes, and we need to see who's doing well, who's doing less well, so we can share and scale things up. Should that function and that repository sit with the National Child's Commission or Commissioner? That's one. It could be Health Canada. UNICEF certainly collects this data as well. The key thing is to have all of these things in one place. So when you're making decisions as policymakers, what you have to do, you have easy access to it, as will the provinces to share and scale things. So all I can do is I can agree with the importance of it. I'm not sure from an efficiency point of view where it actually should sit, but somewhere nationally with national leadership.
What would be some of the data that we should be collecting as it relates to children health?
Well, if you look at the UNICEF 2020 report card, there's all sorts of measurements of graduation rates, poverty rates, food security, housing security, well-being. You look at the Children's Healthcare Canada, which represents the 17 children's hospitals across the country. They collect things on their wait times, including mental health, including surgery, including children admitted for mental health issues, suicides, etc. There's a whole range of data that I think you could probably get a consensus fairly quickly with your child life and health colleagues across the country that we could put together in a concise, easy to find report. And some of that's already being collected. It's just putting it in one spot that's easy to access. And again, that's a discussion that needs to be had as to where that should sit and who should be responsible for it.
Thank you. Back to you again, Dr. Links. In a number of occasions, you talked about, today you talked about the fact that we need accountability. And I'll give you an example. Back in 2017, when the Liberal government allocated $5 billion over 10 years to mental health and spend that money, and today we still don't know how that money trickled down and which services was improved. Number of times you've talked about the clear accountability and measures. What are your thoughts around the new round of conversation that's being had with the provincial and territorial health ministers and the premiers around the fact that we are adding a dimension of accountability through measures and clear outcomes?
I'm 100% for it. We have to have accountability. We have to have outcomes. We have to measure stuff. And if we're going to spend our tax dollars wisely, the taxpayers, whether you live in Chicoutimi or Sydney, Nova Scotia, or Comox, BC, or up in Iqaluit, you have the right to expect that money is being used for the best possible impact. And so I think it's quite right for the federal government to ask the premiers to be accountable and to have comparable, measurable outcomes on all sorts of different things as it relates to health. I think it's absolutely necessary if we're going to get better as a country, healthier as a country, and a better place to raise children.
Thank you, Mr. Chair. I believe I'm all the time.
You are indeed. Thank you. To our witnesses, that concludes a round of questions, and we want to sincerely thank you. I can just imagine that you are all extremely busy people, and your patience and professionalism in handling the questions today is greatly appreciated, as is the expertise that you bring to the topic. We're approaching the finish line in terms of hearing testimony, and then it's a matter of putting it all together and formulating recommendations. But this will be of great value to us in that regard. So thank you so much for being with us. You're free to go to the MPs in the room. We'd like you to stay. We've got some committee business to tend to, and we need to switch over to in-camera for that. Thanks again, everyone.
Thank you for the opportunity.
Suspended. The meeting is suspended.
Merci beaucoup. Thank you.
Thank you.